Good morning, everyone. Welcome to our session. Today, I'm pleased to be with my two colleagues, consultation liaison psychiatrists, and we will be presenting on exploring the potential and challenges of performing ECT in the ICU. I'm Samah Ibrahim. I'm a consultation liaison psychiatrist in Montreal, Canada, and presenting with me, Dr. Dana Hardin and Dr. Drew Cumming. Dr. Dana Hardin joined Ohio Health as a consult liaison psychiatrist in 2021. She is a board certified general psychiatrist and board certified by ABAP for adolescent psychiatry. She currently works as a consult liaison psychiatrist and ECT provider. Prior to becoming a psychiatrist, Dr. Hardin worked as a pediatric endocrinologist and has significant clinical experience caring for transgender children and adults as part of both specialties. Dr. Drew Cumming is a consultation liaison psychiatrist at the Cleveland Clinic in Cleveland, Ohio. He sees inpatient consult on the neurology floors and ICUs and works as an embedded psychiatrist in clinics for movement disorder and neurological autoimmune disorders. During this presentation, I will be moderating the session. I will give small introduction. Dr. Hardin will discuss more the indication of ECT in the ICU and also will elaborate on ethical and regulation aspects related to administering ECT in the ICU. Dr. Cumming will elaborate more on the medication adjustment related to administering ECT in the ICU. So the three presenters, we don't have conflict of interest, and we will start the presentation by a clinical vignette. Mr. T. Mr. T is a young man, 30-year-old, sustained a spinal cord transection and multiple orthopedic injuries after a fall while intoxicated with alcohol. His post-operative course was complicated by respiratory failure and bilateral pulmonary emboli. He also had pneumonia while in the ICU. During his recovery, he developed agitation and delirium, and this required the use of antipsychotic. During an episode of agitation, he had a dislodgement of his percutaneous endoscopic gastrostomy tube, and an emergency laparotomy was needed. After the surgery, dopamine antagonists were gradually tapered and discontinued, and he was transferred to the floor. On the floor, following 1 day or two post-transfer to the floor, he started to develop intense fear, intense anxiety, accompanied with rigidity, mutism, staring, catalepsy, stereotypal movement, and profound withdrawal from the environment, which were suggestive of catatonia. At this point, lorazepam was started and showed to be beneficial. However, that was not able to fully resolve the symptoms. He required a high dose of lorazepam, and this brought him back to the ICU, where high-dose intravenous lorazepam was administered and also to permit adequate ventilatory support. Despite high dose of lorazepam, symptoms escalated and he became febrile with temperature 39 degree, tachycardia, heart rate was 130 beat per minute, and he became diaphoretic and rigid. All the symptoms that clinical picture suggestive of malignant catatonia. In a timely manner, ECT was started as the IV lorazepam failed to solve the symptoms, and especially the worries was the risk of cardiovascular collapse. So for this young man, the ECT seemed very life-saving tool. In the ECT, usually a highly effective treatment for severe psychiatric condition like refractory depression, mania, and psychosis, but also it is beneficial for life-threatening conditions as malignant catatonia, neuroleptic malignant syndrome, refractory status epilepticus, refractory autoimmune encephalitis, and prolonged delirium with catatonic feature. Catatonia is the most common indication for ICU-based ECT. Malignant catatonia is a particular life-threatening subtype of catatonia marked by autoimmune instability, autonomic instability, and can induce myocardial infarction and multi-organ failure and cardiopulmonary arrest. ECT is well established in the outpatient setting, but it's important. The main message, it's also could be administered in the ICU. patients in the ICU, usually they are critically ill and they have psychiatric and medical needs. And ECT should be considered as a comprehensive treatment plan aligned with the ongoing medical management. Sure, there are some challenges considered while administering ECT in the ICU, especially critically ill patients often have multi-organ dysfunction, hemodynamic instability, and dependence on life support measures that requires highly coordinated care. And some challenges could be related to institutional protocols for patient selection, informed consent, and crisis management. And my colleague, Dr. Hardin, will elaborate in details about the indication and the ethical aspect. Also, enhancing the access requires planning, interdisciplinary collaboration, and institutional policies that could streamline the decision-making and facilitate timely care. Collaboration among psychiatrists, intensivists, anesthesiologists, and nursing staff is essential. So, as ECT usually a very well-tolerated intervention. Some contraindications are described in the literature, especially the elevated intracranial pressure, as there is a risk of exacerbating cerebral edema or precipitating herniation. Relative contraindications include a recent hemorrhagic stroke within 30 days or poorly controlled cerebrovascular disease and uncontrolled hypertension or severe cardiovascular instability. Mortality directly attributed to ECT is exceptionally rare, and when complications do occur in patients receiving ECT, the underlying mechanisms are usually attributed to hemodynamic alterations, the effect of anesthesia, and convulsions. So what happened to Mr. T? Mr. T received bitemporal ECT that resulted in progressive and marked improvement in his mental status, and he received 9 sessions. Lorazepam was gradually weaned and he left the ICU. Maintenance ECT was not required. And following ECT, Mr. T became more alert, interactive, and emotionally expressive. His catatonic feature resolved, and he became more motivated, engaged, and emotionally stable. He was subsequently transferred to inpatient rehabilitation, where he became actively invested in his recovery. I saw him in the outpatient follow-up, and he was in a good spirit, oriented and optimistic. He committed to strengthening his upper body function despite being wheelchair-bound. He expressed a desire to regain independence and showed insight and resilience, indicating a sustained remission of his psychiatric symptoms and successful reintegration into his rehabilitation goals. So ECT was really life-changing and life-saving for the case of this young man. And now I invite my colleague, Dr. Hardin, to discuss more the indication of ECT in the ICU and discuss more the ethical aspect related to administering ECT in ICU.
Hi, I'm going to start with a case which I think will bring up some important things that we observe when doing ECT in the ICU. I had a 52-year-old female who had a history of schizoaffective disorder and a medical history of type 2 diabetes, hypertension, and sleep apnea, who was admitted to the county hospital for somnolence, poorly controlled blood sugars, and high blood pressure. The psychiatry team there was consulted to, quote, adjust her psych meds, quote. Catatonia was suspected by them due to her mutism and rigidity. We did not see a Bush-Francis score from them. They did start lorazepam 1 milligram every 8 hours and made arrangements to transfer the patient to our tertiary care center. Unfortunately, her transfer was delayed for 38 hours due to lack of beds. During that time period, I was able to obtain some additional collateral. One was that the patient had not had a psychotic episode for approximately 6 years. Also, that she had quit taking her antipsychotic medications approximately 2 weeks before she was brought to the county hospital. And the reason was given that she was concerned about the meds causing weight gain. And then finally, I was trying to proactively gain informed consent for the procedure. And I learned that this was going to be difficult. It was difficult to know who would be the adequate surrogate decision maker, in the fact that she had lived with a boyfriend for many years. Her sisters did not get along with each other, and sometimes not with her. And then she had a grown son who no one knew where he lived. So the legal team at our hospital said, well, gosh, since we don't know who is the exact person to be the surrogate decision maker, you need to get consent from every single family member. When she arrived at our hospital, her Bush Francis score was 15, but her vital signs were stable. I increased the lorazepam to 2 milligrams every 6 IV, and I ordered ECT for the next morning. During the night, her heart rate increased and her blood pressure became high, and then she developed a fever. I also noted that she had tachypnea, but a blood gas did not show any CO2 retention. I increased the lorazepam dose and the frequency, and that resulted in improvement in her vital signs until immediately before the next dose of lorazepam. The next morning, while in the ECT suite, anesthesiology wanted to cancel the ECT because of her vital sign instability, and they were worried about possible infection due to the fact that she was hyperthermic. I pointed out the normal CBC without any left shift of her white blood cells, the normal chest x-ray, the normal urinalysis. We were still having difficulty despite this. Multiple discussions with leadership occurred, and I got ethics involved. And eventually, our anesthesiologist said, okay, I don't like it, but I'm going to do, I will let you do ECT, but only if we can get her moved to the ICU. So finally, we were able to obtain a bed late in the afternoon on that same day. Once she got into the ICU, our anesthesiologist proactively decided to intubate the patient due to her tachypnea. They sedated her with propofol, and then they intubated her. I do want to point out that her intubation was very difficult. It took almost 44 minutes, and they had to use guided imaging. Thus, there was a lot of airway trauma. Once this was done, I proceeded with the ECT procedure. First, I gave flumazenil 0.2 milligrams twice, given the amount of earlier Ativan that had been given. And I did that 2 minutes apart, waiting a total of 5 minutes. We did use succinylcholine as the paralyzing agent. I administered ECT bitemporally. I used maximum settings with a frequency of 90 hertz, a charge of 576 millicuries, and 101 joules. Her seizure duration was 39 seconds. We did repeat ECT 3 times a week for a total of 4 treatments. Mementin was added after the first ECT. Her vital signs were stable after the first ECT. The rigidity and the staring and mutism markedly improved by the second ECT treatment, and we were able to completely wean her from lorazepam by the 4th ECT. Again, her outcome was good, with good vital sign stability from ECT, improvement in her hypokinetic symptoms, even after the second ECT treatment, ability to wean lorazepam completely. However, she did require prolonged intubation and a subsequent tracheostomy due to the swelling of her airway from the traumatic intubation. 2 months after our ECT was completed, she had decannulation. 2 weeks after decannulation, while undergoing rehab and completing rehab, she was able to go home. This case illustrates several issues that arise when conducting ECT in the ICU. First of all, informed consent. Patients who are sick enough to be in the ICU do not have the ability to sign their own informed consent. Thus, we must determine who will be the surrogate decision maker or makers. We also need to determine who will be in charge of the ECT procedure and sedation, and who will be in the room while ECT is administered when ECT is done in an ICU. And finally, we need to determine the medications that we are going to use, and Dr. Cumming will be elaborating more on this in his presentation. So firstly, let's talk about the personnel needed to deliver ECT in the ICU. Airway management needs to be managed by either the ICU attending, if anesthesia will not be doing the sedation, or managed by an anesthesiologist, and both of those are in conjunction with respiratory therapy. Secondly, medication management for sedation and induction for ECT needs to be a collaborative discussion between the psychiatrist and the anesthesiologist or ICU attending. Thirdly, ECT administration, like in the ECT suite, will be done by the ECT trained psychiatrist. And then lastly, for post-ECT care, the ICU staff will be the primary managers, but it is very important that psychiatry is consulted even up to multiple times per day. I want to talk to you about the ECT settings that we utilized in this case and what is often utilized in our country. First of all, most clinical ECT practitioners start with bitemporal treatments for these type of serious cases. The most common treatment frequency in the US is 3 times per week. It's important to know that the task force report of the APA on ECT recommends 2 to 3 times per week for ECT, and they do caution that more frequent administrations of ECT could result in higher cognitive deficits. In some countries, ECT is done daily in these complicated patients, such as my patient with malignant catatonia. In England, the Royal College of Physicians recommends twice per week for bilateral ECT and states that 3 times per week ECT should only be used in a life-threatening situation. Finally, in all countries, the number of sessions for ECT is determined by the patient response, and it is recommended that no more than 12 treatments in succession be done at the final time until maintenance is administered, maintenance ECT with a delay. This case also brings up the case of regulations and what are the regulations for ECT. So first of all, in the US, the Mental Health Act of 2001 does state that ECT can be given to a person who is involuntarily detained in a mental health hospital. And they also note that that patient must have, quote, serious mental illness, which they go on to talk about being a suicidal patient, a patient with delusions or psychosis, or one who is physically at risk as a result of not eating or drinking. So that's the overarching guideline for our country. Each state has its own set of regulations. So there are a few states that don't have specific regulations: Arizona, Georgia, Maryland, New Mexico, and Rhode Island. There are states that are heavily regulated, such as Oregon, which does not allow ECT in patients who lack their own decision-making capacity, which is concerning given that most patients in the ICU don't have capacity. There are states that require additional consents beyond normal medical consent, and that includes California, Michigan, New York, South Dakota, and Tennessee. And then there are states that require that the administering ECT physician submit additional reporting to the state, and those states include Illinois, Texas, California, Michigan, New York, South Dakota, and Tennessee. State laws do change over time, so it's important that the ECT administering physician be up to date on state laws for their own state. There are also states that have restrictions that are hard to interpret, and I just call this out because it is confusing. For example, Connecticut limits ECT to cases where no other treatment options exist or all other options have been exhausted. And Virginia requires that there has to be clear and convincing evidence that ECT is necessary. In neither of these states does it say who the ECT provider should present the case to and who's the deciding person. Finally, there are states that do restrict ECT by age. For example, West Virginia bans ECT on anyone under the age of 18. There are bans for patients under the age of 16 in Massachusetts, Michigan, New York, South Dakota, Tennessee, and Texas. There are bans for a patient under the age of 12 in California. Colorado bans ECT for children, but doesn't decide or doesn't state what age is considered a child. And then finally, 7 states require a court order for minors, which they define under the age of 17. Also, as my case illustrates, it's very important to note that each hospital system legal team may have its own idiosyncrasies, so you need to check with your own hospital's legal team. So what about navigating issues pertaining to informed consent? There are 2 recognized decision-making standards. The first is one called substituted judgment. And generally that is that the surrogate decision maker is deciding based on what that decision maker has either heard the patient say in the past or has inferred from the patient's behavior or other past statements. The second decision-making standard is one of best interest standard, and that is that the person or persons are acting on the patient's best interest, considering the benefits, burdens, and potential pain or suffering associated with the treatment being proposed. There are state laws that are set for surrogate decision makers, but each state has various surrogate decision maker hierarchies. So you've got to know that. And you also have to know what they state is the standard for decision making. And finally, when each state says that there needs to be a court-appointed decision maker rather than appointed within the hierarchy within the healthcare system. I do want to point out all states recognize advanced directives, but we don't use advanced directives in the case of ECT. And then finally, we need to recognize what is the physician's role in these hierarchies. How do we do dispute resolution if there's differences of opinion within a given family? I had to get 5 different people to consent for my patient's ECT, and I needed to understand what would happen if one of those 5, not the majority, but even one of those 5 had a difference of opinion. And I also needed to understand when I might need a court intervention. Finally, again, just within all things about hospitals, we need to know what our own legal systems idiosyncrasies are about ECT. It can differ from an amputation. For example, for an amputation, and I did ask this question, if 2 physicians agreed it was medically necessary, we didn't have to get a surrogate decision maker. But because it was ECT, I absolutely couldn't say 2 psychiatrists agreed. I had to have a surrogate decision maker. And then my legal team said it had to be every single one of the family members because of that hierarchy being muddy. In my petition for help, I consulted ethics, and ethics can be extraordinarily helpful for us as we navigate these issues. What are indications for administering ECT in the ICU rather than our ECT suite? All of you may know that the ECT suite is already set up like a PACU. Our patients have the ability to be intubated if it's needed. We have an ability to run a code. We have every medication known to God and man and every type of monitoring. So it's a pretty controlled environment. Even so, the ECT suite is separate from an ICU, and that means transport of the patient needs to occur. And therefore, it may be necessary or advisable for the patient to have the ECT administered in the ICU. Cases such as malignant catatonia, cases such as neuroleptic malignant syndrome, cases of suprarefractory status epilepticus, or unstable patients requiring ECT for other reasons such as respiratory failure or vital sign instability. I do want to point out that malignant catatonia is what my patient had. This is a severe life-threatening subtype of catatonia. The key difference between it and hypokinetic or hyperkinetic catatonia is that autonomic instability. The key to saving these patients is a combination of benzodiazepines and ECT administered as quickly as possible. And the diagnosis needs to be made very quickly so that the treatment can be started. In the case of malignant catatonia, I also want to point out that I can use psychotropic medications in these patients. So I want to contrast that to that of neuroleptic malignant syndrome, which is not what my patient had. Patients with neuroleptic malignant syndrome have had recent exposure to fairly high doses of psychotropic medications. My patient had been off of those medications for several weeks. Those patients with NMS typically have severe rigidity as the first symptom. Hyperthermia and vital sign instability develop very quickly. Agitation is almost always present. It is very important to know that neuroleptic medications must be stopped promptly and not reintroduced until NMS is fully eradicated. ECT needs to be started as soon as possible. While we are awaiting ECT, Medications with some success include dopamine agonists such as bromocriptine, muscle relaxants such as dantrolene, and benzodiazepines. Also, just to briefly touch on these patients with status epilepticus, there is good evidence to suggest that ECT can be effective. It is considered a last resort treatment. It's thought to work by providing a controlled seizure under anesthesia, which is different than an uncontrolled seizure such as status epilepticus. And higher success has been documented when ECT in a controlled environment is done earlier in the course of status epilepticus. Also, for patients who are unstable and who require ECT for another reason, the ICU provides a well-controlled environment without the need for transportation between the ECT suite and the ICU. ICUs have access to multiple medications very quickly that can treat the medical issues underlying the reason for ECT. And again, we have multiple personnel on hand to deliver the needed care. Next, Dr. Cumming is going to talk to you more.
Thank you. So I would like to present here another patient vignette. This one designed to demonstrate the complexities of managing medications in patients who need ECT in the ICU setting. So I present here the case of a 29-year-old female who had no pertinent past medical history and a psychiatric history of schizophrenia, who was transferred to our tertiary care neurological ICU for management of presumed neuroleptic malignant syndrome, or NMS. From collateral from her family, this patient was reportedly stable for a long time on maintenance antipsychotics, who had been brought to an outside hospital emergency department with abrupt onset of confused agitation and paranoia. She was admitted to inpatient psychiatry. However, due to frequent and escalating episodes of physical aggression directed at staff, she received a large volume of PRN neuroleptics with subsequent development of a fever, significant tachycardia, and hypertension. Her labs were notable for significantly elevated CK and inflammatory markers. She was transferred to that hospital's medical ICU on hospital day 10, and due to concern for continued agitation and aggression, she was intubated and sedated. On hospital day 21, she was transferred to a separate hospital, which had a neurological ICU, due to continued difficulty in weaning her sedation and extubating her. On hospital day 25, she was again transferred, this time to us and our neurological ICU. On admission, the patient was on 5 continuous sedating medications, yet despite this, continued to demonstrate significant autonomic instability with severe motor excitability with ballistic movements of her extremities, alternating with periods of severe rigidity, all with persistent staring, grimacing, and orolingual stereotyped movements, as well as some intermittent catalepsy. Given the period of time since she had actually received the antipsychotics, we began to formulate her case as more of a malignant catatonia than an NMS. There was early discussion of ECT treatment for her. However, we felt that we needed to optimize and simplify her medication regimen before we would really be able to do so. With all this going on hospital day 33, she had a trach and peg placed. As part of her workup at the outside hospital, she had an LP done, and on hospital day 34, her CSF studies came back positive for anti-NMDA receptor antibodies, suggesting an underlying etiology of autoimmune encephalitis. While we worked to minimize her sedation to handle her catatonia, neurology treated her with a course of IV methylprednisolone, Plex, and rituximab. We were able to get her off of a number of her continuous sedating medications and added on some standing orders for medications both through her PEG and IV, which are listed here. Despite this, she continued to score very highly on the Bush-Francis, at least a 27 each day, which was not helped when we lost access to IV lorazepam due to the perplexingly persistent national shortage of Ativan. So with this, we finally obtained consent and proceeded to ECT treatment on hospital day 57. So with all the medications this patient was receiving, it was difficult to think through how to manage them in order to go ahead and have successful treatment of the ECT. Critically ill patients in the ICU who need ECT are often receiving multiple medications at high doses, which are likely to impact the seizure threshold. Moreover, these patients, by virtue of being critically ill, are going to have a number of changes in their pharmacodynamics and pharmacokinetics that are going to challenge the ability to predict their active serum levels and degree of CNS penetration. If they proceed to the point of being on dialysis, receiving ECMO, then that further complicates our ability to understand what our patients are actually experiencing from the drugs that we administer. So in general, when it comes to these patients, these factors can be helped by focusing on drugs with a lower volume of distribution, which is going to help minimize the impact of large volume shifts, and also utilizing medications which have shorter half-lives so that they can be held before ECT treatment. In general, it's good medical practice to minimize redundant or unnecessary medications, and this is particularly true in these complex, critically ill patients. Similarly, utilizing the lowest effective doses is going to be helpful. For medications that can't be minimized further or stopped, holding the medications that are going to impact the seizure threshold at least one half-life ahead of treatment is usually sufficient. But as you can imagine, patients who are on standing sedatives like propofol, standing benzodiazepines, with medications that are important to manage their agitation or autonomic instability, you need to coordinate the timing of their ECT treatment very closely with the other teams so that their medications are held for as short of a period of time as possible. Now, when it comes to continuous medications or drips, dexmedetomidine is amongst those that are less likely to impact the seizure threshold. During ECT, it can help stabilize blood pressure and may improve post-treatment agitation. So this is one that doesn't necessarily need to be held and actually is often used as an adjunctive treatment option in the outpatient and other settings. With ketamine, this has a dose-dependent impact on the seizure threshold. Below about 2 mg per kg, this can help as an adjunctive sedating agent without challenging the ability to get a successful and adequate seizure. At higher doses, this is actually used as an add-on treatment for superrefractory status epilepticus. So it's important to find that balance in the dosage. For patients on standing midazolam, this should be held at least 3 to 4 hours ahead of treatment. And for patients who have been on this for a prolonged period of time, it's important to consider reversing it with flumazenil ahead of ECT. Patients may be on standing and continuous opioid medications like hydromorphone, fentanyl, or the fentanyl derivatives. These are commonly used also in the outpatient setting as adjunctive sedatives, though there is some data showing that the fentanyl derivatives can be associated with greater heart rate and blood pressure variability. So depending on your patient's clinical status in the ICU, these may be less desirable. Propofol is highly dependent on the individual case. As Dr. Hardin pointed out, for her patient, propofol was used as the primary sedating agent. My patient, who had been on propofol for almost 2 months, they thought that it was likely built up in her system, and so we wanted it held at least a couple of hours before treatment to give us the best chance of getting an adequate seizure. Importantly, propofol cannot be reversed with flumazenil. So for patients, again, with prolonged exposure, you'll want this off for a couple of hours ahead of time. For other GABAergic medications, benzos, if they haven't been continuous, can typically be held at midnight on the day of treatment. If patients have had prolonged exposure with high doses, benzodiazepines are necessarily lipophilic, so they're likely to have built up in the body's fat stores. So anticipating that, you may need to use higher settings on ECT, and will likely plan to reverse that with flumazenil. For patients who have been on barbiturates, whether for seizure management or other indications, these cannot be reversed with flumazenil, so this will require close coordination and collaboration with the other teams to minimize these as much as possible before treatment. If patients are on the so-called Z drugs, those should be held on the day of treatment, but fortunately, they can be reversed with flumazenil. Many anti-epileptic medications, we can actually treat over or through them with ECT. If possible, they should be held at least one half-life ahead of treatment. If we're using ECT to treat a patient with superrefractory status epilepticus, they're likely on 3, 4, 5 or more anti-seizure medications already. So this is another example of times when you have to work very, very closely with the other services involved. If the medications are held before treatment and the patient is thought to seize, important to remember that not all seizures are therapeutic in the sense that ECT is. So if possible, you should still do your best to treat those patients, anticipating that they'll need higher settings because they'll be post-acute. So for medications used before and after ECT, patients in the ICU are likely to have prolonged immobility, resulting in muscle breakdown and hyperkalemia. So for these patients, generally it's recommended to use non-depolarizing agents like rocuronium or atracurium, and agents which are depolarizing like succinylcholine are often avoided. If patients are on high-dose beta blockers and you have concern for the initial parasympathetic surge after the seizure, you can add anticholinergic medications to block some of that impact on heart rate. Given the complexity of these patients, it's always helpful to discuss the primary sedatives with anesthesiology, ICU, whoever is going to be managing it. For patients where it's difficult to get an adequate seizure, the augmentation strategies in the ICU are pretty similar to in other settings. If you need to prolong the seizure, using caffeine and theophylline can be helpful, though they all carry their own risks, which should be balanced given the patient's overall clinical status. If a patient is intubated or trached, this can make it easier to hyperventilate them, and the literature suggests aiming for an end tidal CO2 of about 30. So my patient, she is still under our care in the ICU. She has been responding well to ECT treatment with improved autonomic stability and catatonic symptoms. Her 4th session had to be canceled because her propofol was restarted 1 hour ahead of time by the ICU team, who stated she was so agitated we had no choice. We were able to sit down and troubleshoot that and think of other options like Precedex and Dilaudid, which can be used to substitute propofol in the hours before treatment. After this, there haven't been any repeated issues delaying treatment, though when her propofol is held, she was demonstrating seizure-like activity ahead of each treatment. Fortunately, we were able to add Depakote on non-treatment days, held at midnight before treatment, and she hasn't had any pre-treatment seizures since then. So I would like to thank my co-presenters today for their informative case examples and discussion. Doctors Ibrahim and Hardin, what are our key points to take away from today's presentation?
I would like first to thank you both for this excellent presentation. I learned a lot and it was a real pleasure to collaborate with you in this presentation. I think from my end, the main take-home message that ECT could be really a life-saving tool and it should be started in a timely manner and it's possible to administer in the ICU and it needs collaboration of care and tight discussion and integration and collaboration between different teams implicated.
Dr. Hardin?
I just want to point out that again, that communication with the team, such as your case pointed out, Dr. Cumming, regarding them giving propofol an hour before, we see this kind of thing happen all too often. Or one of the things that happens I see is on patients with tube feedings, the tube feedings get forgotten to be turned off. All these communication things that need to go into our normal day-to-day work as consult liaison psychiatrists seem to be 100-fold more when we're trying to coordinate things happening in the ICU. So I want to make sure that we go the extra mile to communicate. And then on one other point, just to be sure we really do our best to understand the diagnosis. For example, in my patient who had malignant catatonia, I was lucky to get the history that she had not had her antipsychotics for 2 weeks, because if we had thought maybe she had neuroleptic malignant syndrome, then we may have not even restarted her antipsychotic medication early enough. So there's lots of things as we learn more to share with our teams. And I think all of that communication, which is why we liaise, is going to make for the very best outcome for our patients.
So thank you so much. And I hope that our listeners enjoyed this talk. And thank you for your listening and see you next year. Thank you both.